Good morning, everyone. Professor Kemal Aydınat, thank you very much for this wonderful presentation. You are one of the most distinct personalities, and it's an honor for me to be moderated by you. We're going to discuss psychopharmacological treatment and resistance in autistic spectrum disorders. When I was called by the organizers to talk about resistance, it was Bengi who called me, and I said at once, yes, I will do it. I never thought whether there's resistance or not, but as I was getting prepared for the panel, I asked myself, what's resistance? So today's speech will be about that generally. What is the outline of the speech? First of all, how much time do I have? 15 minutes. Okay, so that means I'm going to have to speak very quickly. First of all, what's the definition of resistance in autism or autistic spectrum disorders? Is there a medical treatment? For which cases should we say there's resistance? This is a fairly good way to start. Which areas did people work in? Why do clinicians use medication for autism, and what should be done with certain groups of medications in principle, and then I will talk about my clinical experience and the experience of the authors to come up with a model. We all know that there is no medical treatment to autism. You can target symptoms of autism through certain educational, social, and verbal training programs. Despite this fact, we know that 80 to 90% of the cases, autism is prescribed a medication. Clinical data and research can be reviewed, and will result in the fact that usually the drugs are targeting symptoms. What are these target symptoms? Stereotypies, hyperactivities, tantrums, tics, compulsions, anxiety, irritability, sleep disorders, sexual disinhibition, especially for adolescents, and what the families complain the most, sensory hypersensitivity. When we review all these treatment methods, we realize that there isn't a study on any medication to cure or to treat autism. The expectations are, for example, families want the child to sleep at night or not to knock down windows, to break windows. So in autism spectrum disorders, can we talk about the treatment-resistant group, or can we talk about diagnosis-related challenges and similar challenges? Generally speaking, we have, by the way, Wednesday meeting that we discuss such cases, and we see 8 different types of antipsychotics, 5 different types of ADs, olanzapine up to 40 milligrams, risperidone up to 4 times a day, no sleep, etc. Those cases are discussed. Are these resistant cases? Instead of using the term resistant, I will make a recommendation at the end of the speech. So what's the problem? Even such humble expectations are not met. First of all, there is an insufficiency on the road to diagnosis. Most of the autistics are regarded as disabled, and there could be some psychiatric disorders. It's thought that every tantrum is just a tantrum and not a depression, and they believe that atypicals should be prescribed for each of these anger cases. But this could be a non-specific symptom of something else. Because it's a diagnostic problem, 8 different drugs are tried, nothing works. They come to us and multiple prescriptions don't work either. But if you turn back and look at the history, we can find out that the patient may not have used the drugs for for the required duration, no compliance, or maybe psychiatric status was not reviewed. Secondly, families. Families should equip us with enough information for us to be able to understand the case, but most of the time they have wide autism phenotype. They cannot observe well enough, they do not have enough verbal skills, they just say, my child is tearing apart everything, etc. So when does the child do that? How frequently does he do that? To what extent? They don't really observe that. So the relationship between you and the family, the communication is important. They should give clear messages, and so should you. Another important point is physicians sometimes fail to understand the difference between a child and an adult. And a disabled child would be different than a disabled adult. Those drugs which are effective in the treatment of adult autistics may not be useful in children or may activate certain behaviors. This is a disabled child. A disabled child and a disabled adult are subject to different principles. So if we're working with a group of children, we need to be careful about that. We need to know about the duration of treatment to prevent relapse and to inform the families. These are the drugs that have been worked, psychotropes, as you know. Looking now at atypicals, these are the most widely prescribed antipsychotics in Turkey for all spectra of autism. Sometimes we don't know why. In the US, in certain schools, SSRIs come forward, but in Turkey, atypical antipsychotics, as far as I've observed. There could be reasons, but probably because we're focusing on symptoms, anger and irritability. The most frequently used with an FDA approval is risperidone. We can say that there are 70 or 80 case studies or placebo-controlled studies, and adding onto this the reviews, 144 articles can be found in PubMed. The long-term and short-term effects have been analyzed. Temper, tantrum, aggression, hyperactivity, stereotypies, adaptive functions are well affected in the short run. In the long run, the RUP group had made a study in the US checking its 4-month effect, and there's a 3-year study from Italy showing that for similar symptoms, it may provide certain relief. Risperidone, by the way, is the most frequently used one, and I'd like to give some detailed information about some trials, some studies. We see that it's effective on certain symptoms, but there is also the side effect of weight gain, hyperprolactinemia, increase in appetite, somnolence, enuresis, encoparesis, and GIS hemorrhage. Furthermore, for children, the doses, the safe dose is 0.01 to 0.1 milligram per kilogram. This is the safe dose. We must start with a smaller dose, and in order to prevent relapse, use it for at least 6 months and taper it slowly, because if you in 62% of the cases there's a relapse if you cut it after 6 months. In 40% you don't. You cannot say the patient may fall in this 40% group. 2 to 3 years, under 3 years we don't use it because there is no safety well defined. It has caused cardiac problems in a couple of children. Looking at olanzapine, this is usually for moody children with no control over their angers. There are a couple of studies. Side effects is again weight gain. Quetiapine, there is no really a study that stands out. Looking at ziprosidone, there are some studies on especially adult autistics. There's weight gain, hyperlipidemia, hypercholesteremia. So a study has been conducted with ziprosidone. Anger is under control. Hyperlipidemias are tackled. For children, if you use it in lower doses, and if there's no response to other medications, it can work. Aripiprazole is relatively new, and there are 2 studies. And the results are contradictory, because one study says that the target symptoms of 5 autistics were well affected. Another one says it's not effective in autistics, but it's effective in mentally retarded. I think it's still early to say anything about these drugs. Antidepressants, clomipramine has been the one that's been studied the most, and especially for adult autistics, it had a positive effect on repetitive behavior and general compliance. But for children, there are some side effects, from seizures to extended QT interval, tachycardia, etc. So it's not preferred. SSRIs are widely used, and the reason is the serotonergic dysfunction hypothesis in autism. Fluoxetine has been worked on the most, especially after over 2 years of age, starting with very low doses and aiming at repetitive actions. Fluvoxamine, we have some very important data on that, and the data are as follows: 2 or 3 important conclusions. One, it gives a better result in adult autistics. For children studies, we see response being very weak once you use it at adult doses per kilogram. Then they ask the question whether it's got to do with the dosage. And they realize that if you treat autistic children with the same dose of the adults, 4 milligram per kilogram of fluvoxamine can be administered, but for autistics, it should be a maximum 1 milligrams maybe to get the result without behavioral activation. So this was a study that added on to our knowledge about SSRIs. You should use it at lower doses. That's the message. Sertraline may be used at low doses for anxiety, irritability, and repetitive behavior. Paroxetine has only a case study. Citalopram seems to be a bit moderate. There are 2 studies. 10 milligram in average works on compulsive behavior, anxiety, and mood. Finally, how are the SSRIs used? There are usually repetitive behaviors, anxiety treated by SSRI. In order to prevent behavioral activation, we should start with the lowest dose. For example, Prozac syrup, half a teaspoon, and then titrate it up in a certain period of time. Because if you start with 10 milligrams, you will see behavioral hyperactivation, and the family or you will discontinue. Mirtazapine. 2 groups made a study on that. We, for example, we did this for sexual disinhibition. That's a serious problem in early hyperactive children. We realized that masturbation has been stopped with mirtazapine at night, and it will be published in Journal of Psychopharmacology. In 9 of these cases, there were fetishistic obsessions and sexual assault, and these were seriously, considerably reduced. I will pass on that because there's just one study. Psychostimulants are important, so let's discuss that. In attention deficit hyperactivity disorder, that's different from autism, DSM-4 says, and you cannot put the same diagnosis. But comorbidity study shows that 30 to 50% of the autistics are also showing ADHD symptoms, and psychostimulants are used to a high extent. What's the problem here? DSM-5 is going to change it, and so it will be solved. But they do not respond to psychostimulants like adults. To very few of these psychostimulants do they respond well. So we have to come up with the right target group. For example, if an individual's IQ is over 45, I'm talking about autistics, they can respond to a certain extent. The dosage should be 0.3 milligrams per kilogram. That's well tolerated. But when you titrate it to up to 0.6 milligrams, they become more hyperactive. It's better than in Asperger's syndrome, but there are some side effects such as social withdrawal, and that's very scary for the families. So we should start with very low doses, well-functional cases. Coming now to mood stabilizers, not many studies, so I'm passing on to lamotrigine, not being much different from placebo. Topiramate, usually for weight control. Canitano, an Italian scientist, works in the field of psychopharmacology and used topiramate and says that it's good for weight control only. Naltrexone seem to be very hopeful for a while because social skills are improved and it has a positive effect on child-mother bonding, according to animal studies. In the 80s and 90s, this was very hopeful, so we do see a lot of work. And very rarely did we see naltrexone working. I know I'm running out of time. Can you give me 3 minutes? Secretine. Younger ones won't know that, but a few years ago, families asked us, should we give the patient secretine? That's probably the most well-worked, hardest worked drug. A placebo-controlled trial on 500 children, so we can say very clearly that it has no effect. Atomoxetine, that's a new option, and we will discuss it in the National Congress, so I'll skip that. If this is the case, all studies picked target symptoms. What should we do? First, a well psychiatric examination, confirm the diagnosis. You should know the premorbidity. Sometimes people say there's no premorbidities in autism, but you will take a look at the history and realize that until age 6 the child was okay. After 6 the child became irritable, fighting with others, etc. So we need to know the functional level before the morbidity. Furthermore, which symptoms arise when, that should be analyzed, because that will take us to psychiatric diagnosis, and under which circumstances do these symptoms arise. Furthermore, is it sensory hypo or hypersensitivity? Is it because is it because of the clothes of the child, the outfit, that turns them into a hypersensitive? How about relationship with other individuals? For example, hostility towards the mother. They don't hit the father or the teacher, but the mother. The time of the day is important for ADHD cases as well. They become more irritable at night. And we could always remember that there could also be some physical problem accompanying that disease. Parents usually come to us and secure their coming 5 years. They don't come to us in the next 5 years. I saw a patient at 3 years of age. We gave him risperidol, 0.3 milligrams. 3 milligrams per day. And the parents used to call me every day and said, I now increased risperidol to 0.5 milligrams at night because the child doesn't sleep. And I said, okay, I hope he sleeps at night. And the next day the parent called me and said the child had otitis media, and why didn't you diagnose that? So even when you are forced to say yes on the phone, it can be a problem for you. You should see the patient always. Educational programs may be related because they are usually focusing on academical success, not social skills, darker rooms, etc. If they are kept in dark rooms for 5 years in such an educational system, there is no way they can not be depressive. Irritability, hyperactivity, tantrum. What will we discuss? What are the psychiatric comorbidities? ADHD, 45 to 70%. Depression, what are the symptoms there? Irritability, anger against the most favorite person, social withdrawal, sleep disturbances, increase in stereotypies, compulsions, or in these cases there could be depression and you should switch to AD. Looking at anxiety disorders, especially OCD and specific phobias, should be examined. OCD, for example, in parents, mother and father should move their hands in the same manner. This is the 5-year follow-up of my patients at the office. This is in English, sorry about that. 37 Asperger's group has everything in the 5-year follow-up. 94% have any psychiatric disorder, from generalized anxiety disorders to what have you. 45% ADHD, 32% OCD, major depression 30%, tic disorders 20%, and suicidality 16%. None of them arrived saying they have depression. Looking at Hagenar's and mine dissertation, this is the autistic group with an IQ over 70, the ADHD 60, specific phobia 53, KGB 30, and OCD 20%. So we see that autistics are susceptible to other psychiatric diseases. So the conclusion is there is no clear etiopathogenesis in autism. Only 25% of these cases are explained by genes. Finally, 6 genes have been defined, and we have the honor for that. Because it's heterogeneous, it's difficult to find a drug for it. But comorbidities can be treated with medications. So we should know these comorbidities and start medications to save the children's lives. If not from autism, we can save children from dysfunction. So the problem here is not resistance. The problem is understanding the psychiatric disorders, psychiatric diseases,